I'm Saffron Caudry and I'm Deputy Chief Executive at NHS Providers, and I'm delighted to welcome you to this session, which is an in conversation with Dr Habib Naqvi, and really delighted to have Habib with us today. As you may know, Habib is Chief Executive of the Race and Health Observatory. As you've already gathered, to participate in this session, you need to have the headphones on. And as soon as I finish speaking, I will also be putting my headphones on. Ditto Habib. So we hope that this will be an opportunity for us to really get underneath some of what the Race and Health Observatory has been doing and really raise our awareness of where health inequalities lie within the communities we serve and their impact, and think about the data, getting better data and how we use that data. And I think one of the key elements of this conference, and particularly the work we at NHS Providers and the Race and Health Observatory are trying to do, is really to make tackling racism, tackling health inequalities part of core business. So I'm going to hand over to Habib for around 10 minutes of presentation. Then we've got probably 15, 20 minutes of conversation. So over to you, Habib.
Brilliant. Thank you very much. Saffron, can you all hear me? Brilliant. Fantastic. Well, it's great to be here with you today. It's great that NHS providers are focusing on this particularly important and critical agenda. I will be talking about the importance of data in reducing ethnic and racial inequalities in health. And I always start my talks and my presentations with the data. And what we know, in fact, of the NHS is that what doesn't get measured doesn't get done. But having had those conversations with my colleagues just literally 20 minutes ago, they've reminded me that actually we've had this data for not just years, but for decades in the NHS. It cannot be right that today, in 2023, black women are up to 4 to 5 times more likely to die during pregnancy, childbirth, or soon after. We know of the issues around access to mental health services, particularly for young black men. We know of the impact of COVID-19 on our ethnic minority communities and healthcare staff as well. And so there is a level of urgency for us to focus on these data. And in a way, our country, our healthcare system should be well equipped to deal with this level of urgency. Why? Well, because we have a long history of migration in this country that goes back decades, if not centuries. We therefore have large and growing ethnic minority communities. We have fairly robust legal frameworks in the Equality Act and the Health Inequalities Duties, and we've always had very good investment in healthcare research in this country as well. However, it can also be argued at the same time that our collective responses to these kinds of data have been somewhat fragmented, costly and confused. And whereas specific organizations, think tanks, have been set up to focus on these issues in the past, they have, in my opinion, arguably focused on surface level issues without looking at what we call in the observatory the causes of the inequalities that we see, the causes of the data that we see on this slide. We in the NHS Race and Health Observatory were established just over 2.5 years ago. We were set up by NHS England as an independent organisation, primarily to hold up a mirror to the rest of the system around these data, but not just to highlight the scale of the challenge, but also to provide very clear and robust action points that organisations and system leaders can take forward. One of the first things that we did was to carry out a systematic review of the evidence base to give us an indication of what is it that we should be focusing on during the first 3 years of the observatory's life. And as you can imagine, we came away from that particular exercise with a very long list of things that organizations and leaders wanted us to focus on. This slide highlights some of those things, some of those agendas that we are now focusing on around maternal health, around mental health, around sickle cell disease, around inequalities in the workplace as well. This report did make the press, and it did make the front page of The Guardian last February. And the reason why it made the front page of The Guardian wasn't because it was just another systematic review that was presenting evidence and data and insight around ethnic and racial inequalities in health and healthcare. But it made the front page because we were focusing on and committing to action that looks at the causes of the causes. And that includes some of the structural issues that we see within society, including, of course, structural racism that leads to some of the inequalities that we see and the stratification that we see in terms of access to services, in terms of experience of those services, and in terms of the outcomes that we saw on the previous slides. And therefore, we went about looking at focusing on exactly that, the causes of the causes. And this slide highlights our kind of anti-racism approach to some of those challenges, including, as I mentioned before, on the left-hand side, some of the structural issues, the structural racism that we see within society in terms of education, in terms of employment, in terms of the other structural issues that we see so vividly across society as a whole. But also on the far right side, you can see some of the interpersonal racism in terms of cultural assumptions, in terms of trauma, in terms of stigma, in terms of the behaviors that we observe and encounter on a day-to-day basis. And of course, the structural racism and the interpersonal racism do come together in terms of our institutions where we work. I always say the NHS is a microcosm of what happens in the wider world. What we see in society is bound to be reflected in the 1.4 million people that work across our healthcare system. And that's about, therefore, the policies and the practices that we have within our organizations that play out and have been there, in fact, for years and for decades. And I will come on to some of those biases a little later on. We operate in the observatory on the basis of 3 stages, and we call these the 3 legs of our operating model. Firstly, to bring together the evidence base where it exists, or to establish the evidence base where it doesn't exist. Secondly, turning that evidence into policy recommendations for change. And thirdly, supporting organizations and healthcare systems to implement those policies on the ground. And in fact, the very first piece of work that we did during the observatory's lifespan was to look at racial bias in pulse oximetry, which is our report on the left-hand side. What we did here was to bring together the evidence base around the biases that we saw in pulse oximetry during the start of the pandemic, which was obviously affecting levels of oxygen in people's blood and bodies. We then had very clear recommendations for change, the second stage of our operating model, including for NHS England, including for the MHRA, the regulator, including for NIHR. And then we went about to implement the third stage, which is supporting those organizations to take forward those recommendations. And on the back of our report, we had the NIHR put out a very substantial call for further evidence because the majority of the evidence was from the US. There was limited evidence from the UK. We had in fact NHS England who updated their guidance on the NHS Choices website around pulse oximeters. And we also had the Secretary of State for Health and Social Care at the time, Sajid Javid, who announced the independent review into equity in medical devices on the back of our report as well. But that piece of work was interesting because it highlighted our independence. And although we were set up by NHS England, we were in fact also holding up a mirror to NHS England, an organisation that within days were going to roll out tens of thousands of home pulse oximeters. And in fact, we did hold the line, and we were brave in saying that actually we need to look at some of the guidance around this particular device, and the importance of doing that was critical during the early part and the rest of the pandemic. On the right-hand side, you will see the neonatal assessment report, and I won't go into too much detail around this, but you can find that on our website. The fact is that the APGAR score, which many of you will know, which judges the health of a baby minutes after its birth, which came out in 1952, has a level of racial bias within it. Judging the health of a baby partly on the basis of the color of its skin was not right in 1952 and certainly not right today in 2023. So we are working on focusing to level out and filter out the racial bias in that particular assessment. That's just one example of a huge range of assessments, medications that we see within the healthcare system that have a level of bias built into them. And some of that is because there is a lack of representation in clinical trials for some of these devices and some of these medications. And some of the work we're doing at the moment is, for example, as this slide shows, to look at increasing representation in clinical trials for breast cancer, working with Macmillan Cancer and Roche to have a number of sites, including the Christie in Manchester and Barts Health, and putting out a number of interventions that can increase representation so that actually when we have devices like the pulse oximeter, for example, or we have medications, we know that they are there to serve the majority of our population and all of our populations, and not there to serve some of our populations as we move forward. And of course, we know of the link between engaged staff, and I always highlight this because we also have data around staff and the discrimination, the bullying and harassment, the lack of opportunities that our black and minority ethnic staff experience on a day-to-day basis across the NHS. And that relationship between happy staff and happy patients, engaged and looked after staff, and better outcomes for our patients is well established and well evidenced. And focusing on that is important because if we're in the business of tackling health inequalities, which we are, then we need a workforce that's engaged at all levels. My final slide is around what is it that we can take away. Some of the recommendations around improving data quality and analysis. These 6 points are from the work that we carried out with the Nuffield Trust a few months ago and we published, highlighting the quality and consistency of improved data, taking out the not stated, the unknowns and the others, and really focusing on the detail of data and data collection is absolutely critical. Analyzing data on a routine basis. And then the third point, which at the top, which I find really interesting, the methodological approaches should be clearly defined. We saw how data was presented in, say, for example, the CRED report, which we saw published just over a year ago, and how data was analysed in a way that presented a particular picture around ethnicity and around race. We see how, for example, the ONS mortality data, which is experimental data, gets presented by some to give a particular picture. And we need to be very clear. We need to hold true to our values and our morals and make sure that we have an open mind, but also an honest heart when it comes to data analysis and being true to the values of the NHS as we move forward in analysing data as well. The other point I'd like to highlight before I hand over to Saffron is the final point on this slide, which is the role of the regulators. In my time, I'm working at NHS England and now knocking on the regulators' doors to get them to be serious around this agenda, and in the context of data, to be particularly serious around incorporating the quality of data coding into their inspection regimes and their ratings is absolutely critical because we know that what keeps chief executives awake at night partly is their CQC rating. And if we can build this into the inspection regimes, and of course we need people to do this because they want to and not because they have to, but we also know that regulation, assurance and contract are important levers for us to move ahead on this agenda as well. I'll pause there because I know there will be comments and questions.
Down with me, and I'm mic'd up. And also puts his mic on so that he can talk to us. But just thinking about a couple of the things you said there, which I think were really, really important. So we talk in many ways about things like structural issues and structural racism and structural inequalities, but I was really struck by this notion of the causes of the causes, which is a much more accessible way, I think, of describing this. And I thank you for that phrase, because I'm going to nick it and use it all the time, because it feels really important to have a more accessible way of talking about structural inequalities and how we tackle them. I'm going to open up to questions now. Please wave if you've got a question and the microphone will come to you. While you're thinking, I am going to ask a quick question to you, Habib, which is really about, you've presented the data and you've talked about accountability and regulation, and they're really, really important in terms of reducing inequalities. But we know that that isn't always part of core business across the NHS. So if you had a wish, how would you change trust board behaviours to make this core business?
Well, I would say that it is core business, Saffron, because the very reason that if you get this agenda right, you are likely to have an impact upon staff engagement levels, you're likely to have an impact upon increasing patient safety, patient outcomes, and also an impact upon efficiency within the NHS. And we know that there are cuts to the NHS, but if we have a look at, say, for example, the elective backlog, which is a topical issue at the moment, if you focus on an equity lens and have a look at reducing potential inequalities that may emerge by not looking at the backlog from a tackling inequalities lens, then you will make savings, and you will treat people that are most in need of treatment. You will avoid a time bomb in the future around issues around public health and issues around outcomes, etc. So, the two are not separate. Getting this agenda right will mean that you will get the agenda right for healthcare delivery and efficiency for the NHS.
Thank you. Okay, I'm going to open up to questions. Got a gentleman here. Please wait for the microphone to come. Can you say who you are and where you're from?
Yeah, thank you, Habib. I'm Dr. Kunigri. I'm the medical director in Lincolnshire Partnership NHS Trust. This is really exciting, but just following on your answer with regard to dealing with health inequality, can you just explain in practical terms that I work in mental health, so we have huge waiting times, particularly with regard to camps. So how do you think, as a medical director of my board, help in terms of dealing with waiting list in line with the health inequality? Because the place where we are, there are lots of farmers and also a lot of seasonal workers coming from Europe to Lincolnshire. So can you just give me some ideas so that I can think through and then follow it on? Thank you.
Thank you.
I think it's about breaking down your list and looking at the patient list, but breaking it down by characteristics. What we say in the NHS Race and Health Observatory is rather than looking at broad levels of ethnicity, for example, if you can go down to specificity by default, we call it, by looking at individual groups and looking at their needs, looking at who's been on the waiting list for how long, what are their comorbidities, what are their risk factors, and kind of stratifying the list in relation to need and not demand. I think the NHS and organisations will be better placed. We did a piece of work with the Nuffield Trust on the elective backlog, and there is a report that we published on the back of that, which is published on our website, highlights very clear examples of that. And one of the infographics I showed on the slide earlier presents kind of 10 practical steps that organisations can take in order to focus on the elective backlog in a very practical way.
Thank you. Got any more questions from the floor? Any more hands going up? If not, I'm going to ask another one, because it's my prerogative as chair. But I think you've talked a lot about data, and I think data is clearly the kind of foundation on which we kind of, you know, make the evidence base speak for itself. But what do you think the practical steps are that trust leaders can take to improve both their qualitative data and their quantitative data?
So I think that's an important point, Saffron, is it's not just about quantitative data, and very often we do hear from organizations and from leaders that we don't have the data to hand, but it's looking at turning data into insight, or getting that insight, and very often it's not just about quantitative data, it's also about the engagement that you have with your communities, with your patients, with your workforce, that holds that kind of rich information. So it's about turning the data into insight and turning that insight into action, which is absolutely critical for us to do that. But as I go back to my previous lines, it's about leaders leading all of the people all of the time, and not some of the people some of the time. So, you know, yes, having an open mind, but an honest heart when it comes to analyzing data and focusing on things that you should be focusing on as an organization, which in fact are aligned to the values of the Constitution, ensuring everyone counts.
Yeah. Thank you. Got a lady here who's got a question.
Thank you very much, thank you. My name's Mary McLean, I'm Chairwoman of Royal Cornwall Hospitals Trust, a long way away from here. Thank you so much for that presentation. Listening to you, I feel awful. And my question is around, you gave two really good examples of the oximeter and the APGAR. And I'm just wondering why we can't change that now, because the evidence is there. So my question to you is, have you identified what are the barriers to us implementing some really obvious, potentially quick wins? Thank you.
That's a great question, Mary. Thank you.
Well, some of that is down to not focusing on the short term. We know that the current government will be going into an election cycle and maybe not focused on some of the long-term kind of ambitions that perhaps it should be focused on. Tackling inequalities in health and health care is something that you cannot do overnight. It will take a longer period of time. So investing in that long-termism is really important. But it's also about kind of building the level of trust, I feel, with communities, with patients and with staff as well. And what we saw so vividly over the pandemic was a breakdown in levels of trust and confidence. And in fact, what Kevin Fenton, who's on our board, very often says is that trust is fast becoming a new determinant of health. And if we focus on the right things, if we are able to weed out the biases that we see that are so obvious in pulse oximeters, that when we know the evidence, in the APGAR score, in anti-cancer drugs that do not get broken down in black bodies as quickly as they do in white bodies, have led to higher levels of toxicity and deaths, which we know. If we can weed that out, not only will we be aligned to our own moral compass, pointing in the right direction, but we will be, as I said before, doing the right things in terms of patient outcomes, patient safety, and also saving the NHS a huge amount of trouble and money as well. Critically so, looking after our patients and making sure that they're safe.
Thank you, Habib. We got any more questions? We've got a few minutes left. Just checking to see if we've got any hands up. Nope. I'm going to ask one, which is, you had a really good phrase on your slide, which was excuse remover. And I just wonder if you can give a couple of examples of what really good excuse removers are, because along with cause of the causes and trust becoming the new determinant of health, I think this feels like a key phrase to me. So
it does, and in fact all three are related. So if you think back to the example of COVID-19, we heard from high on up some of the reasons why ethnic minority communities and staff were disproportionately impacted, more likely to live in high, multi-story buildings, flats, more likely to have comorbidities, more likely to work on the front line. But what wasn't talked about was why is that happening in the first place, i.e. the causes of the causes.
Yeah.
So the excuse removers are understanding why is it that black and ethnic minority people are likely to work on the front line, less likely to find themselves in the boardroom. Why are they more likely to have comorbidities and not looked after in terms of their diverse needs? Why are they less likely to find themselves living in open space areas, more likely to be on the 42nd floor of a high-story building? So those are some of the excuses that were highlighted. And for us as an organization, it's about removing those excuses. And it's about looking at the causes of the causes, which include some of the structural issues, discrimination and racism that we see within society that plays out in our organizations that we need to weed out. Some of that is explicit, some of that is implicit as well. Some of the biases that we see within medical devices and medications has been there for many years. But now that we know that they exist, it's our objective, I guess, and mission to make sure that we take those out.
Thank you so much. And I think everyone will agree that Habib's presentation and comments today have, I think, really shone further light on just what we've got to grapple with here. And I think some of what you were talking about there just resonated with some of the awful stuff we heard a few weeks ago from the COVID inquiry about, thinking about what's the impact of some of the decisions that were taken around things like impact on domestic violence and free school meals. And there was no diversity in that number 10 room that was making those decisions, and some of clearly the wrong decisions were taken. And I think that really resonates with me in terms of thinking about how diversity in decision making and diversity in representation around a decision making table is so critical.
Yeah, I mean, just on that point, Saffron, what we saw when the pandemic broke out were emergency response structures across the NHS, which were largely made up of NHS board members who were not diverse in the first place.
Yeah.
And therefore, decision making was not diverse. We did not have diversity of thought going in to decisions, for example, around the disproportionate impact of the pandemic amongst our communities, but also critically our healthcare staff. And I don't need to repeat the statistics around the first X number of doctors that passed away that were from an ethnic minority background, and nurses, etc. as well. What we did when I was at NHS England very quickly was to bring together a group of people, senior leaders, including the then Chief Executive of the NHS, Lord Simon Stevens, who chaired the session, around what is it that we can do pretty quickly. And we brought together the res experts, and we sent a letter out to all NHS trusts highlighting the res experts that were present within their regions and within their localities, and to involve those within some of that decision making. And that led to a number of things around, for example, decisions around PPE, decisions around supporting local public health departments around vaccine uptake, etc. As well. But it's about making sure that we tap into the diverse talent that we have, and where it doesn't exist, because we know of the structural barriers within the NHS, there is kind of an imperative for leaders to make sure that they focus on breaking down those barriers, so that we do have learning from the many lessons that we've learned over the COVID pandemic, and that does include looking at increasing representation at all levels within the NHS.
Habib, thank you so much. It's been a great conversation, and thank you for everything you and the Race and Health Observatory do.
Thank you so much. Thank you very much.